I will talking about the femoral artery revascularization with combination of brachial radial and pedal approach. The radial approach is one of the safety approach and better comfort for the patient and for the team. From the date of the interventional cardiology clinical trials, the radial approach is very safety from the femoral or brachial with very low complication rate. What happened with, we know what happened in interventional cardiology. The radial approach is the approach for the first step for the intervention, diagnostic. For the peripheral artery disease, for the diagnostic, it's a very good choice. What happened with intervention? In the last year, the more endovascular specialists take the radial approach for the peripheral vascular intervention, but the very long distance from the radial to the distal stenosis, it's still a problem. But we not have the bleeding complication, and I tell again, the comfort for the patient is very big. And for that, most of the specialists want to use this approach for the intervention, but we still have obstruction. Brachial approach. It's the comfort for the patient, more from the femoral approach, effective option with the patient with femoral bypass, and with previous intervention, endovascular on distal aorta and iliac artery. For the crossing from the femoral, it's not easy when we have implanted the stent in the distal aorta or in the ostium of the common iliac artery. But in some patient limitation of the light of the device, it's still is the problem. This is our publication for the safety of the transbrachial access. We used more transbrachial from the last year, and for that we want to see the safety of the brachial access, and we do retrospective analysis. In this analysis, we see the brachial approach, it's more safety than the femoral approach, with the low MACE in the group, in the patient with brachial approach. The brachial approach is in the safety approach, but it must be careful for the hemostasis. This is the date from the one study for the peripheral intervention with brachial artery access. It's the safety and efficacy. Pedal approach, one more very safety and comfort approach for the peripheral intervention we see in the session this morning, and can be one of the solution for the peripheral intervention, because now the device is with very low French, and it's one of the solution. What happens when we can combine the tibial pedal approach for the endovascular therapy and radial or brachial approach? It's a very good solution. We take two very safety and comfort for the team and for the patient approach. And it's very important because we see the successful open with the new device of the femoral occlusion, it's very high. Now we can do something for the comfort of the patient, for the comfort of the team. And combination of this approach, femoral brachial with tibial, it's a very good solution. I say this morning I take the angiographic methods for the pedal approach. We see here, after injected of the contrast, puncture of the artery, and contrast, we can see, go out from the needle. This is our experience with peripheral intervention. We can see the before 5 years, we have only 2 dowel approach, and every year the number of the dowel approach go up, and successful of the procedure, it's the same, go up. We have only little number of the combined brachial or radial approach with compared with femoral and tibial approach, because why do I take the radial brachial approach and tibial only in the patient with previous aortofemoral bypass, stenting on the this zone, and only with patients with very indicate for this situation. In other patients, I take a tibial approach only for the finish the case, the open artery. This is the first case with general atherosclerosis, with stent and femoral artery on the both sides, instant thrombosis of the femoral superficial artery in the left. This is the angio. We see the total stent thrombosis. I try to going from the brachial axis for the open, but after the stent, I'm going on the false lumen. We can see on the second movie. And for that, one other reason for the going the tibial approach is that this is very huge collateral, and it's not possible to go down with the wire and catheter. For that, I take the femoral tibial approach, do the true false lumen. After that, with tips wire from the distal catheter to the proximal catheter. We can see here, I'm going from the pedal approach from the microcatheter to the proximal microcatheter and do through and through. Predilatation, and this is final result for the artery. Next case, again with the general arteriosclerosis, with occlusion of the femoral artery. We have here step on the proximal femoral artery, but we not can cross from this occlusion. For that, we think that it's better to going from the tibial approach for the crossing from the occlusion. But in the distal occlusion, it's not possibility to crossing with wire. I take the go-back catheter. The go-back catheter, when you open 45%, the needle is straight, and you can use for the crossing from the distal cape. After the crossing, we crossing from the all of occlusion in the false lumen. False lumen coming, going to the common femoral artery, and now it's very easy to the crossing from the proximal cape to the same false lumen. And we again, after kissing balloon cutting of the intima, connect the through wire, and after dilatation, this is the end stent implantation, sheetless from the pedal approach, supera stent. And the next case, because I see that I not have time, again, patient with generalized atherosclerosis. This is the angio. We not see the ostium of the femoral artery, but we crossing from the proximal cap of the occlusion. After that, we going with tibial approach, and I want to back to the see one huge collateral. We use this collateral because it's with only true lumen. We put the wire on from the proximal and distal part, and after the dilatate from the distal part, we place the lasso for the take the wire from the proximal and to do through and through. Can you please only last?
Панел на този екран.
Само последното. We can see here the wire crossing from the lasso, and here we going through and through. After stent implantation and balloon dilatation, this is the final result. Take-home message: transradial transbrachial approach for peripheral intervention is safe and effective alternative of femoral one. Pedal approach is safe, effective, and associated with less contrast and radiation exposure. Retrograde pedal approach offer alternative endovascular option. Dual approach with radial, brachial, and pedal approach offer multiple endovascular strategy in complex peripheral pathology. Thank you.
Okay, thank you, Dr. Stankov. Some comments and
of course.
questions?
Of course. When it comes to radial, I am very fascinated by the radial. I do this approach also very often. So the problem with the radial artery is if you treat the aortoiliac lesions, you can do that, even complex aortoiliac lesions. But when it comes to SFA, you need a second puncture site. And the pedal is a very good one for that because the length of the balloon is not enough to treat the SFA when you come from the radial approach. There are some devices in the market, but they are too expensive to use. So with this one, with one radial and one pedal approach, this is, we can say, how you can solve an SFA problem minimalistically. We can also call this a minimalistic approach in endovascular treatment. So I congratulate Zoran for this presentation, and I am also a fan of doing this kind of procedures.
Yeah, in fact, our friend Zoltan Ruja, he was the author of this overview of this analysis from Hungary, and he was one of the pioneers, one of the promoter of using a radial and pedal approach. Definitely, like you mentioned, it's really minimalistic. The problem is sometimes the radial artery puncture is quite long distance from the target zone. Yeah. So in case the target zone is around the popliteal, the distance is quite long, and because of that reason, we are puncturing the brachial. So we are, let's say, gaining 40 centimeters more. Yeah. And in our experience, like we published, the complication rate is very low. There are several reasons for that. One of the reasons is that the French size of the devices went down from the past. From this past in which the brachial approach was considered very dangerous, but for 9 and 8 French, Now with 6 French approach, the complication rate is extremely low. We have at least 500 brachial punctures per year, so the complication rate is not big, and we have a very good judge, and the judges are our vascular surgeons. So because is there a complication, the vascular surgeon is receiving the complication for correction. Okay. So definitely it's not very often. And because of that, we can combine radial or brachial, depending on the distance. The good news is that the long sheet is nowadays, there are 110 centimeter long sheet from Terumo, from Cook, from different companies, I think from Merit. So there are many producers of long sheets. And this, in fact, is making closer the target to the tip of the sheet. That is with a very good support. And because of that, our threshold to switch from simple crossover to pedal, it's absolutely very lower now, because we have quite good results with the combination of brachial pedal or crossover pedal. So, and like you have seen, sometimes we are meeting the wires, and we are snaring the wires even in collaterals in order to be sure that both wires are in the same lumen. In case they are not, we are making the rupture of the membrane with a kissing balloon maneuver. And yeah, there are different tips and tricks that are helpful. Okay.